And today's CME is on the futuristic approach to the management of tuberculosis. We have a good panel of doctors here, and this will be moderated by Dr. Shyamala Menon, who is the senior physician at the Medical Trust Hospital. So I'll call Madam to the stage, and along with Madam, shall I call all the panelists as well, ma'am? Dr. Abraham Ittyachen, the HOD of Medicine and the Consultant of Critical Care at the Kolanjeri Medical College. Dr. Jilse George, Government Medical College, HOD, General Medicine. Dr. Akhilesh, who is a Professor, Department of Respiratory Medicine at the Amrita Institute of Medical Sciences. And Dr. Deepa from the Department of Microbiology at the Medical Trust Hospital. So I'll hand over to Dr. Shyamala to take it forward from here.
Good evening, everybody. Greetings from API Kochi. I'm sure that all of you know that there has been a paradigm shift in our national tuberculosis policy from that one of control to elimination. This was in tune with the WHO's global initiative, End TB campaign. And because of this, the new campaign, National Strategic Plan, has been introduced in 2017 by the Government of India, and there are 4 components to it: detect, treat, prevent, and build. Prevent component of this National Strategic Plan is a very important component, critical component of this program. And today, we are going to discuss the essentials of this prevent component of National Strategic Plan under PMTPT, that is Programmatic Management of Tuberculosis Preventive Therapy. My panelists have already been introduced, so I'll go directly to the questions without wasting time, because they have got some other ceremony also after the CME. First question to Dr. Jilse. Simple question. What is the difference between tuberculosis infection and tuberculosis disease?
As we all know, tuberculosis is caused by an organism called Mycobacterium tuberculosis. India has the highest estimated burden of TB globally, with nearly 35 to 40 crores of population having tuberculosis infection. Of this, 25 lakhs of people is estimated to develop TB annually. 2 terms we have to remember. One is the tuberculosis infection and the tuberculosis disease. Tuberculosis infection is a state of persistent immune response to stimulation by Mycobacterium antigens with no evidence of clinically manifest TB disease. Most infected people have no signs and symptoms of tuberculosis but are at the risk of developing TB disease later. That is the importance of identifying the TB infection. TB disease is a disease that occurs in someone infected with the Mycobacterium tuberculosis, characterized by the classical symptoms and signs of TB. They will have positive X-ray finding, they will have positive blood results, they will have positive sputum examination results, and there will be tissue involvement on biopsy or FNAC. Currently recommended test for TBI are: one is tuberculin test, second is the interferon gamma release assay.
Thank you, Dr. Jilse. So we know that there are 2 terms, TB infection and TB disease. Now the question is to Dr. Abraham Ittyachen. We know that we are focusing on the TB infection part in the preventive component of National Strategic Plan. Can you explain why?
Actually, to be very frank, part of the question has already been answered by Dr. Jilse. As he has just mentioned, in India we face a huge burden. As per the records of our own government, the maximum number of people with TB infection in the world, the global burden, is in India. Nearly 45 crores of people there with TB infection. And please remember, TBI is different from TBD. TBI infection is different from TB disease. Of this 45 crores, around 25 to 26 lakhs become, or rather develop the disease every year. And if you take the case of our state, we have a high density population. In fact, if you look at all the states in India, ours is the highest density of population. And we all know, right from our MBBS days, how easy it is for TB to spread, especially the pulmonary form of tuberculosis. So therein lies the importance of controlling even TB infection. Unlike in previous years, government used to give importance only to tuberculosis disease. Nowadays, the dictum is we should also treat tuberculosis infection in the particular risk groups, because every patient with tuberculosis infection is a potential source of infection to others, and we all know, along with the burden of TB, there is a huge rise in the incidence of drug-resistant tuberculosis. Of course, we will be coming to that in the panel discussion, and that's the state of the TB burden in India, and that is why it is important to treat both TB infection and not only TB disease, and that is the position in India and in our state.
Thank you, Dr. Abraham. That means there is a huge reservoir of TB infection. I remember our olden days, because even I used to tell the patient, when Manto is positive, even I may be positive because I'm exposed to it, but I don't have the disease, so I don't have to be treated. Times have changed, and now that pool, the TB infection pool, is the target. Universal screening probably is the ideal thing, but because of resource crunch and our large population, it may not be so. So, Dr. Akhilesh, what target groups have we identified in this program?
Thank you, madam. First of all, congrats to the organizations, IMA Kochi and also the Association of Physicians of India for selecting this important topic. Now coming to my question, this is about target population. Already before introducing this PMTPT regimen, we used to treat HIV and children with LTBA regimens. Now there are some expansion to that group. Now all the HIV children less than 12 months with contact history of this pulmonary tuberculosis, that also included, with just treat policy, means ruling out of active tuberculosis, then treat. But household contact more than 5 years also is included now with the test and treat policy, means we are ruling out tuberculosis disease, then we are ruling out tuberculosis infection by Igra, then we will treat. That is the new addition in the this children group. Up to 18 years is called as children, and in Kerala guidelines suggest 5 to 15 years. Some regimens are there, 3 HR, will come to later, and this is about this children group. Now all the household contact can also be included in PMTPT as the target population for this TB preventive treatment. Household contact of pulmonary tuberculosis at present, later it may be implemented in another sectors like smear negative tuberculosis, extra pulmonary, depends upon the feasibility, etc. Other expanded groups including all the immunosuppressant groups, like those people who are using this immunosuppressant medications like TNF-alpha inhibitor, infliximab, JAK2 inhibitor like baricitinib or tofacitinib, then high dose steroids, 15 milligram per day for more than 1 year, more than 1 month, that also can be included in the target group. Then some other group like silicosis or transplant group, organ transplantation, this dialysis group. These are all the newer expanded target groups as per the current policy. Thank you.
Thank you, Dr. Akhilesh. Dr. Abraham, having identified the target groups, there must be an algorithm for screening them, for excluding certain cases. Can you expand on that?
No, unlike I mentioned in the previous point, to the previous question, unlike in previous years, nowadays we are supposed to go. Basically, when we say we are supposed to go, it is a government level. We are supposed to go into the community, and actually the government has specific guidelines. The health workers, every week, they are supposed to report to their higher authorities the risk factors or people at risk for TB. Now, we all know about the effect of HIV and TB, people who are coming in contact with a sputum positive TB. But in addition to that, as Dr. Akhilesh just mentioned, there are some new groups that have come in, which I would say is the result of progress in medicine. One is people who use TNF receptor antagonists, and probably you are all aware of some of these drugs that were used during COVID. And regarding some of these drugs, in fact, if you look into the drug literature, it's very clearly written, any patient who receives a TNF receptor, that is a tumor necrosis factor receptor antagonist, TB should be ruled out. Then we have silicosis, patients with organ transplantation. So these are all newer groups that was not present before. The traditional groups like HIV and diabetes, we are all aware. Now we have newer groups. The other thing is, patient who develops HIV, he is at 25% risk more than a non-HIV person to develop TB. A person who is even otherwise exposed to TB, he may not have the same risk. So once you identify the risk factors, in fact the guidelines say some of the basic things which you have learned long back. The classical symptoms of TB like fever, cough, night sweats, and weight loss. Now these are the classical symptoms of TB, and these are basically used to rule in tubercular disease. Now coming to tuberculosis infection, which Dr. Jilse pointed out, we use TST and Igra, that is tuberculosis skin testing and interferon carbon-related assay. HIV has got a special issue because though people with HIV, we do screen and rule out TB, in those with tuberculosis disease, we treat them, and even without disease, we are supposed to give them preventive treatment. About the drugs, I think we'll be discussing that, though I'll briefly touch on that. It's actually 6 months of INH or INH plus rifampicin weekly for 3 months. So the gist of the topic is, unlike previous years, now we have newer groups where we have to focus on. The second thing is, it's not just tuberculosis disease, but tuberculosis infection also.
There must be some exclusions. Active tuberculosis, hepatitis.
That is regarding tuberculosis infection and the disease. There are groups where we have to be very careful about treatment, which for whom we did specialized treatment. A patient who is allergic to drugs, a patient who is an alcoholic, patient who has got active hepatitis, and especially before you give tuberculosis, what Madam just mentioned, that is the programmed management of tuberculosis preventive treatment in India, that is the short form she used. You have to rule out tuberculosis, active tuberculosis, before you give treatment for preventive treatment, because both are different.
I think they all mentioned some lab tests. Dr. Deepa, can you tell us the lab tests which are used for the identification of tuberculosis infection?
Yes, ma'am. Yes. So as said, excluding active TB disease is the most important step before starting TPT, and confirming TBI before starting TPT will increase the certainty that individuals targeted for TPT would benefit from it. So as I want to say that there is no gold standard test to diagnose TBI or predict progression to TB disease among those infected. And currently available tests, as said, TST and Igra, they measure an indirect immune response of the subject when exposed to a TB antigen. So next slide, please. So these are the, you all know tuberculin skin test and interferon gamma release assay, otherwise Igra. These are the two widely used tests for testing TBI. And TST is an in vivo test which measures the delayed hypersensitivity reaction to a crude antigen. And interferon gamma release assays, they measure the amount of interferon gamma released by the WBC when they are exposed to specific antigens contained in Mycobacterium tuberculosis. Next, please. So I'll just give you a comparison between TST and the Igra test. If you take the specificity, TST has very low specificity when compared to Igra. Why? Because the antigen used in TST is a mixture of antigens of Mycobacterium tuberculosis, Mycobacterium bovis, and non-tuberculous mycobacteria or environmental mycobacteria. Whereas in Igra, the antigens used are very specific. They are very specific proteins found only in Mycobacterium tuberculosis. So Igra, the pooled specificity of Igra in any population, BCG vaccinated or non-BCG vaccinated, is very high. So false positive results due to BCG vaccination is not a problem in Igra. Then coming to sensitivity, both tests are very sensitive. I mean, there is no gold standard to compare whether this is compare these tests. So an accurate measurement of sensitivity is not possible. Both tests are sensitive. But having said that, I would like to add that a negative Igra or TST in a healthy individual has 100% predictive value that this will not progress to TB. But the same negative test in another clinical scenario, for example, if you are suspecting a patient is having TB and you are having a negative TST or Igra, how much accuracy that test has is questionable, because TB itself is a cause of allergy. All these tests require an adequate immune response from the patient to get a reliable result. So a negative test does not rule out TBI. And of course, TST has been decades old, it's very cheap, so it is widely available. And Igra, whereas it requires a very good laboratory infrastructure, logistics, and high cost is there. And interpretation of TST is subjective, whereas Igra, the interpretation is robust. It is an accurate automated lab method. And when you consider special population like children or HIV, where the immune response may not be adequate, Igra always scores better than TST. Next slide, please. So whom to do testing for TBI? It's not a requirement for initiating TPT in people living with HIV or children aged less than 5 years in contact with pulmonary TB patients. And in children or household contacts above 5 years and adults, TST or Igra should be offered wherever available. And all efforts need to be made to ensure that testing is made available, but TPT should not be deferred in their absence. So overall, if you ask me which test is better, Igra performs well better than TST in any group of subjects, but the limitations are its cost and the logistics involved, and it's not easily available as TST anywhere. Thank you.
So the question will arise, is Igra available in our state or near about Kochi?
It is available in Muvatupuzha Center.
I've heard Muvatupuzha Government Medical College, yes. And I think Public Health Lab. Public Health Lab, yes. Not in GH. Not in GH. I don't know why. Yeah. And it is free also.
Free of cost in government sector, of course. And in private sector, it comes to about 2,000 to 2,800, 400 rupees. And most of the hospitals don't have Igra in-house. We are all outsourcing actually to other labs.
Thank you, Dr. Deepa. Dr. Akhilesh, the actual regimen. How do you treat these TBI patients?
Okay. There are several regimens was proposed by earlier WHO guidelines, like we conventionally used 6 months of INH, 9 months of INH, or 4 months of INH rifampicin. There are a lot of regimens were available, but the current national guidelines suggest mainly 2 regimens, that is 3 months of INH plus rifampicin, that is weekly once, and 6 months of INH. That I will come to that details in which group. First of all, this short rifampicin regimen containing regimen, that is 3 HP regimen, and all other regimens are almost similar efficacy. there is no difference between the efficacy among 6H, 9H or 3HP. But the complaints to the 3HP regimen is better. Completion rate is almost 20% better than the 6H regimen. That is 62% in 6H, whereas in almost 82% in this 3HP regimen. Adverse events, hepatotoxicity, these all are lesser in 3HP regimen. That's why this 3HP regimen is preferred compared to 6H regimen. But still in certain groups, like in pregnancy, the safety data of rifampicin is not available. In that case, pregnancy, we have to opt for this 6H regimen. Then in a drug-drug interaction, means like in HIV groups, again 6H regimen will be preferred. Kerala has adopted, means Indian Association of Pediatrics has formulated the guidelines before the national guideline itself. So the IAP has already suggested 3HR regimen, that is 3 months of INH plus rifampicin up to 15 years of age group. That is because they were familiar with that regimen and good complaints rate with that regimen earlier also. So currently Kerala is following that regimen up to 15 years of age group. After 15 years of age group, 3HP regimen is being followed. And in, these are the major regimens currently available and the pros and cons.
By the way, probably 4H, they may not be knowing what 4H and I think 4H is isoniazid.
Oh, okay. 6H is
6H is isoniazid and the other one is one question, how many of you have used rifampicin? Anybody? No, but it is in the guideline. I have no experience, neither all these professors, they also don't have any experience. So I think whatever we know, rifampicin, I think we can use that. Now, how will you monitor? I mean, you have given the treatment to the contacts, but they should be kept under surveillance. So what are the important points when, you have to follow?
Yeah, the most important thing regarding the TPT is either to start INH for 6 months or to start 3 months course of INH plus rifampicin. While the patient is on this regime for tuberculosis preventive treatment, we have to look whether the patient is going to develop any active tuberculosis. That we should not miss. So whenever a patient on TPT develops fever with evening rise of temperature, cough, night sweats, weight loss or hemolysis, we have to consider the patient for investigation for development of overt tuberculosis or tuberculous disease. Look for any abnormal X-ray finding, evidence of systemic organ involvement, or even we can go for biopsy and or lab investigations. Along with this, we have to look for any adverse effects of the drug. That is also very important while we are treating the patient with the TPT regime. The drug which we are widely using is the INH. INH will produce 2-3 very important side effects. One is asymptomatic elevation of liver enzymes. While on treatment with INH, we are frequently come across with elevation of SGOT and SGPT. If it is less than 3-fold increase, there is no need to stop the drug. There is no need to stop the drug. But when there is elevation of serum bilirubin with elevation of SGOT and SGPT, we have to temporarily stop the drug until the results of SGOT, SGPT and serum bilirubin comes back to the normal. Another important side effect is the peripheral neuropathy. That means the patient on TPT will complaints of tingling, numbness and paresthesia of the upper limb and lower limb. Here what we suggest is, whenever we are treating patient with INH, it is better to give a prophylactic dose of pyridoxine to all patients. Children 10 mg and adult it is 25 mg. Once patient develops peripheral neuropathy, we have to administer 100 mg of pyridoxine daily. That will take care of the situation. Another important side effect we are facing in our setup is skin rash. When there is skin rash and itching, only thing required is to give an antihistamine. But Whenever the lesions are seen in the mucocutaneous area, or when there are bullous lesions, or when there are ulcerations in the mucous membrane, we have to immediately stop the drug, and there should not be any attempt to restart the drug, because there will be fulminant reaction to this drug later. So we have to select a different regime for treating TPT. Regarding rifampicin, it is also hepatotoxic, but the main problem we are seeing is with rifampicin is gastrointestinal problems, that is abdominal pain, abdominal upset, vomiting, nausea, etc. So the better guideline to tide over this situation is we have to administer rifampicin along with food. That will reduce the symptoms. Then thrombocytopenia purpura, generalized cutaneous reactions, and such all other things are very rare complications of rifampicin. Regarding the rifampicin, I am having no experience in using rifampicin because it is not available here. Here also gastrointestinal reaction, hypersensitivity reaction or flu-like symptoms, hepatitis, discoloration of body fluids. Discoloration of body fluids is a very important symptom. You have to tell the patient earlier in advance, otherwise they will stop TPT. The saliva will be red in color, the sweat will be red in color, tears will be red in color, and even the semen will be red in color. So patient will come back saying that there is hematuria or there is blood in their body secretions. So these are the major side effects we are facing while using TPT drugs. Then another important thing we have to keep it in mind while using this drug is these drugs are produces drug interactions with the anti-arrhythmic drugs, antibiotics, anticoagulants, anticonvulsants like phenytoin, we are using it widely. Then antidepressants like amitriptyline, nortriptyline, antimalarials, antipsychotic, antivirals. So that list is little big. So drug interactions also we have to keep it in our mind. Then there is another question, how to restart the drug once the patient develop complications. There we have to go into details.
I think anyway, the message is clear. During monitoring, look for active tuberculosis. The person is not a patient. The contact may develop active tuberculosis during administration of the TPT regime. So you have to be on the lookout for that. You have to be on the lookout for the side effects, and you have to be on the lookout for drug interactions. These are the three things. And of course, the counseling for adherence, because we know that drug adherence is a big problem in India, and we have to see that the patient takes the drug as prescribed. Okay, we have come to the last, the final thing of the first part. Second part, we know that MDR tuberculosis, drug-resistant tuberculosis is also a very big problem in our country. What about the contacts of drug-resistant tuberculosis? How are they treated? Dr. Abraham?
No, basically, it's actually a burden of drug-resistant tuberculosis. Now, in the previous question, I had answered that, I pointed out that the guidelines, the data from the government and WHO says that there are around 45 crores of tuberculosis infection in India, and around 26 lakhs annually develop TB disease. Few years back, they did a survey on drug-resistant tuberculosis, and it was quite surprising. Around 26% it seems were drug-resistant. So that comes us to the top, takes us to the topic, what is drug resistance? Now, our guidelines are not very clear, so I had to go into the WHO guidelines, which is actually a little more easy to understand also. Most of us physicians are aware of MDR TB, what is called as multi-drug resistant TB. But there are other types of resistance also called monoresistance, polyresistance, and XDR TB. Monoresistance is resistant to one drug. Polyresistance is resistant to two drugs other than INH and rifampicin. Multi-drug resistance is resistance to INH and rifampicin, and we have XDR. XDR means it's actually X starts with X, but the expansion is extremely drug resistance TB. And that is where you have resistance to fluoroquinolone, which are recommended in the ATT regimen, that is moxifloxacin and levofloxacin, and one of the second-line injectable drugs like capreomycin, amikacin, and kanamycin. And one point which I'd like to point out here is, traditionally we have all been taught that streptomycin was a first-line drug. It's no longer considered a first-line drug. It's actually considered a second-line drug, and you use it as a reserve drug when you cannot use amikacin. So therein lies the classification of drug-resistant TB. And of course, according to the drug resistance, we have actually the different regimens for the drug resistance TB. In fact, WHO classifies into 3, about which my colleagues will be talking about.
Dr. Deepa, how do you diagnose drug resistance?
Drug resistance testing we can broadly classify into genotypic testing or molecular drug resistant testing and growth-based susceptibility testing. So under this molecular variety, we have the CBNAT or Gene Expert, line probe assay, and whole genome sequencing. So CBNAT, this is the Gene Expert MTB RIF assay. This is a cartridge-based nucleic acid technology, which is a self-contained, benchtop, robust, nested PCR. And this detects genetic sequences within MTB complex and also mutations in the RNA polymerase gene, which is associated with rifampicin resistance. So the results are obtained from sputum samples or extrapulmonary samples in less than 90 minutes, approximately 80 minutes, with very minimal biohazard and very limited technical training is required. You can just train a technician one day and the next. This is not at all a complex process, very easy test to do. But the instrument requires an ambient temperature setting, means it needs an air-conditioned room and a very good UPS for the functioning. Then another upgrading of MTB RIF is the Ultra. The MTB RIF Ultra has a limit of detection of around 15 to 16 bacilli, which equates it almost to the sensitivity of liquid culture. And in the pipeline is Expert MTB XDR, which will give you resistance to fluoroquinolones and other second-line injectable drugs. So this is the CBNAT we have, and the similar technology is TrueNAT, which you all have heard during the COVID pandemic. So TrueNAT also has a chip-based PCR technology for detection of MTB. The technology is same, and results are available in 2 hours. The advantages of this TrueNAT is it is easily portable. It doesn't require a UPS. It's battery operated, so we can use it for field work. So these are the 2 screening molecular tests that is available. Then comes line probe assay. Line probe assay also uses PCR technology. Here PCR technology is used to produce amplicons, and it is hybridized to probes which are immobilized on a paper. And how the probes bind to the wild type and the mutant type, from that bands, colored bands, resistance is inferred or detected. So several mutations, you will get a detailed report of whether resistance is inferred or detected according to the mutation and mutation bands. That is when the sample is subjected to line probe assay. Next in the line is, and it may be the game changer for tuberculosis diagnosis in the future, that is whole genome sequencing. It's a process of next generation sequencing, and it can provide near complete genome of Mycobacterium tuberculosis and rapid detailed sequencing of different regions. So this is a sample report you see. You can get the information on resistance to almost 18 to 20 anti-TB drugs and the entire antibiogram of the isolate. And also it will help you to see the linearity or epidemiological purposes. If a cluster of TB is there, whether one strain is related to other, all this information we can get from whole genome sequencing. So CBNAT has been the game changer of TB diagnosis now, but in future that will be WGS. That's about the molecular. Now coming to the phenotypic assays or growth-based susceptibility testing. We all know that the earlier LJ medium, solid medium, TB culture and sensitivity, these are discontinued because of the longer turnaround times. So now liquid culture based assays are done. Everybody must have heard about Bactec Midget 960. It is an automated liquid culture system. The reading is done, the reading is obtained as a fluorescence. How much amount of fluorescence is produced, that gives you an indication of whether tuberculosis bacilli is present or not. And in the same kind of tubes, we can perform susceptibility assays to first line or second line TB drugs. So this, the difference from molecular technology is that these kind of liquid culture and DST can be used to monitor the treatment response of the patient. Because molecular tests, once positive and once mutation is detected, it cannot be used for the response monitoring of the patient. So in India, quality assured DST to rifampicin, INH, pyrazinamide, moxifloxacin, levofloxacin, linezolid, amikacin, kanamycin and capreomycin are available. The TAT is around 7 to 21 days from positive culture. And this is a diagnostic algorithm. I am not going into the detail. Next slide, please. The take-home message is CBNAT is more sensitive than smear AFB microscopy. That is one thing I want to tell everyone, that now the focus has to be shifted from smear AFB. Whenever you suspect a person for or patient for presumptive TB, the first diagnostic step should be CBNAT from whatever possible sample you can get. And upfront CBNAT is the diagnostic modality wherever TB is suspected, because it gives you results within 80 minutes and it gives you an information about rifampicin resistance. Whether you are treating or diagnosing an MDR TB, the information is on your fingertip within 1 to 2 hours. So if rifampicin resistance is detected in CBNAT, go for first line LPA, second line LPA and liquid culture DST for these drugs has to be set up. According to that, the patient has to go in for a shorter bedaquiline based regimen or a longer MDR XDR TB regimen. So the take home message is, please understand that CBNAT is the first line diagnosis of pulmonary or extrapulmonary TB. And I just want to add one more point. Previously I talked about Igra and TST. Please don't use Igra or TST for the diagnosis of active TB, because that is a common practice, I think. When you suspect TB, Igra or TST is ordered, but TB diagnostic algorithm is totally different from TBI diagnostic algorithm. So CBNAT is the game changer.
The other point is, it's mandatory. As per the Government of India guidelines, every specimen has to be subjected to CBNAT to check for resistance.
Yes.
That is it.
But many a times we see that sometimes the sample is only sent for AFB culture, not CBNAT. For smear microscopy and AFB culture, a lot of samples come, but that smear microscopy has to be changed to CBNAT. CBNAT is the first test that you have to do. And LPA is very underdone, I think, in private sectors. Most people go for liquid culture and DST, but LPA is a very good test and it gives you information about resistance in a turnaround time of 1 to 3 days. So that's the 2 points I want to stress upon.
Thank you, Dr. Deepa. We all stand educated. Next is, I think, the regimen itself for drug-resistant tuberculosis. Very brief.
It's a very important slide, because whenever a patient or a medical officer or a staff comes in contact with a drug-resistant tuberculosis, they will immediately come and ask what to do. So the answer is, there are two options. When a patient is rifampicin resistant, we can use levofloxacin alone as the drug of choice for treating or for controlling tuberculosis preventive treatment. The dosage of levofloxacin also very easy to remember. If the body weight of the patient is less than 45 kg, 750 milligram daily for 6 months is the dosage. If the weight of the patient is more than 45, it is 1 gram per day is the dosage. So once patient is rifampicin resistant, we can go for levofloxacin 500 milligram once daily for 6 months. The dose schedule in pediatric I already given. Then if the patient is rifampicin sensitive, we can use 4 months rifampicin as the drug of choice. If patient is rifampicin sensitive. So the dosage is age more than 10 years and older, 10 milligram per kilogram per day is the dose. And if age is less than 10 years, it is 5 milligram per kilogram per day is the dose. So rifampicin or levofloxacin we can use. Safer drug is levofloxacin, and effectiveness wise also levofloxacin stands first. So it is very, very important to remember whenever a patient comes to us with history of contact with a drug resistant tuberculosis. Next, another common question or common situation we are facing is the missed dose. Patient will come and ask us, doctor, I missed 2 doses while on treatment with TPT. Another question is, I 1 week marunnu kazhichilla, I out of station ayirunnu, I yatrayillayirunnu, then what I have to do? So the answer is, whenever a patient is on 6 months INH regime, or 6 months levofloxacin regime, or 4 months rifampicin regime, less than 2 weeks is the period he missed the drug. The answer is resume TPT immediately upon return and add the number of days of missed doses to the total regime, treatment regime. Suppose we missed 5 days treatment, add 5 days extra to the total treatment regime, so that the total duration of treatment will be extended by another 5 more days. If it is more than 2 weeks, if treatment interruption occurred after more than 80% of the doses expected in the regime was taken, then continue and complete the remaining treatment doses as per the course. And if less than 80% of the doses expected in the regime was taken, and the treatment course can still be completed within the expected time for completion, that is the treatment duration plus 33% additional time we have to take the drug. So continue and complete the remaining treatment doses in the total course of the treatment. Then suppose we are taking 3 HP regime, that is INH plus rifampicin regime, weekly schedule of up to 3 doses missed. So here we are taking the drugs weekly. If missed dose is remembered within 2 days of the scheduled day, the person can take the dose immediately and continue take remaining doses following the same schedule to complete the course. അപ്പോൾ ഒരാഴ്ചയിൽ ഒരു ഗുളിക നമ്മൾ മിസ് ചെയ്തിട്ട് 3 ദിവസമായി, അടുത്ത ഡോസ് കഴിക്കുമ്പോൾ നമ്മൾ ഓർക്കണം ആ ആഴ്ചയിൽ 2 ഡോസ് കഴിക്കരുത്, പിന്നെ ഒരു ഡോസ് കഴിക്കുന്ന ആ ദിവസം മുതൽ അടുത്ത ഡോസ് ഒരാഴ്ച കഴിഞ്ഞേ കഴിക്കാവുള്ളൂ. ദാറ്റ് ഈസ് ദ ഗൈഡ് ലൈൻ ഇൻ ദി guideline for the missing of a dose or 2 doses while patient is on TPT.
Thank you, Dr. Jilse. Now, how do you assess the endpoint, the outcome that we have succeeded in our TPT, and how long actually does this TPT, the effect, how long does the effect last? Is it permanent, or do you have to repeat it again?
Actually, we have given a time period of not 100% of the days for the completion of the TPT, because we have given an extra 33% of time for completing the TB preventive treatment. Suppose for 6 INH, there are 239 days are available for completing the treatment. At least 180 days he has to take the treatment. At least ideally he has to take at least 180 days. At least this 130, at least 144 doses has to be taken. That is, within this additional 33% of time, 80% of the doses has to be taken. That's for 3 HP and also for 6 HP. So 6H. So for 3HP, out of 120 days, ideally 12 doses has to be taken, minimum 11 doses has to be taken. If they are completing 80% of doses within the 133% of the timing, that is 33% additional timing, that can be called as treatment completed. Now, who is treatment interrupted or lost to follow-up? Lost to follow-up means for 3 months of INH and rifampicin, if more than 1 month dose is missed, that is called lost to follow-up. For 6H, that is 6 months of INH, if more than 2 months of doses are missed, that is called lost to follow-up. Who is failure? Failure means those patients who has developed active TB disease during the completion of during the course of the treatment, and those people who are who died during treatment due to any cause, that is called death. That is called died. That is the outcome definition. And TB discontinuation due to toxicity, that is because of adverse drug reaction or drug-drug interaction. Sometime it has to be discontinued. In that case, it is called TPT discontinuation due to toxicity. One more point I had to clarify means earlier we told that rifampicin, the national guidelines are suggested if rifampicin is not available, we can use 6H, not rifampicin. As per the national guideline, if for 3HP is not available in any state, they can use 6 months of INH. And currently Kerala is having this 3HP regimen is available in all districts, but it is available only in district TB center. We have to refer to concerned district TB center. That is logistical issues that will be coming to the private sector later.
Thank you, Dr. Akhilesh. Now, all this while we have been talking theory. I heard Dr. Jilse saying that if a patient comes to us missing the dose, actually the patient is not, that person is not going to come to us. There is another mechanism. And since Dr. Akhilesh is very much involved in the program, this TB program, I think he will be the ideal person to tell us how this cascade approaches. Suppose a patient comes to Dr. Abraham and he is diagnosed as TB. What do we do? How do we, proceed with the, the rest of the things? How to, screen the contacts and reach the contacts first. And who are the people who are actually involved in the implementation of this program? Because I'm sure that, like me, when I read this, I thought, എന്തൊരു മനോഹരമായ നടക്കാത്ത സ്വപ്നം. That was the dialogue that came to my mind. Because it is so complicated, I don't know what is happening on the ground. What is the reality?
So cascade of care approach means we have to find all 100% of the people are things to be as the target population. Means we have to find out the index case first. Index case, how to find out the index case? That is by either active case finding, door-to-door surveys, or current this vulnerable population, means in migrant populations or geriatric homes. So intensified case finding or passive case finding whenever the patient comes to our system. That is one modality. Second modality means institution where these high-risk populations are being there, like those rheumatological center or a dialysis center or cancer institute. In those areas, we have to find out some mechanism for screening for active tuberculosis. Then we have to find out contact tracing, means overall household contacts. We have to find out from various registers. We are having all the registers for this because we are updating all this list in the NICSHI portal also. So
That's
from this NICSHI portal, we will be able to identify the active cases. We can find out the contacts, and from ART center, that is another mechanism. From ART center also, we will be able to find out the index cases and also the contact tracing.
No, so suppose I have a patient of tuberculosis. What should I do next? Who should I, contact, or how do I report it?
So whenever you are having an active tuberculosis concerned health facility or the wellness center or any healthcare facility, it can be primary health center or it can be a private healthcare facility, you can contact and you can do a screening for tuberculosis with symptom analysis or chest X-ray, and from that this cascade of care start. Whether they are having, can you show that slides? Whether you are having an active tuberculosis, first you have to rule out tuberculosis. If you don't have tuberculosis, then you rule out TB infection. This is the slide. So
no, what I meant was, Dr. Akhilesh, there must be other people because this has been called a people's movement. This TB Mukt Bharat says that it is a people's movement where the doctors are involved, the paramedicals are involved, the other healthcare workers, the community is involved. So what is the role of each of one of those? That's what I meant. Because in a private hospital, if I have a case, what should I do? Should I use I can't contact them, I can't call all the contacts to my clinic and find out. So who should I contact, or where should I use an app to upload it?
Currently from Nikshay app we can find out the details and we can update the list in the Prevent TB app. If there is any eligible population, we can update the list in the Prevent TB app also. That will be later updated to another application in the as per the national guideline. Currently, we can use only this Prevent TB app and the Nikshay portal for getting the index cases and as well as the people eligible for the target population also. And as Madam told, actually everyone is responsible. Now there are newer concepts called TB-free neighborhood also. But the stigma is so much prevailing. So we can just involve so close the health facilities or family doctor or the concerned healthcare worker, maybe a JPHN for getting this contact tracing and all these things.
Counseling is extremely important in these cases because they don't have a disease, and to get a person without disease to take medicine is difficult, and I think counseling is a very important part of this program. I think we have...
Madam, one more thing
okay.
I can just add. Because though the cascade of care approach is a very good approach, at only 20%, less than 20% are being completed the cascade of care approach. We are screening, we are finding out, but when we are referring a patient to a district TB center for starting TPT, they are not going. Or we are sending for Igra, it's not available, or it is not getting tested, the test is not getting. So because of lot of reasons, there are a lot of dropouts or loss. So that is being completed in less than 20%. If we are completing 100% of cascade care only, we will be able to achieve this TB elimination strategy in 2025. Thank you.
So the ground reality is different, but I think if you all of us put our heart to it, it's a Herculean task, but we will be able to do it. If not by 2025, let's say 2040 at least. So with that, we have come to the end of our session. Panelists will be happy to answer any questions from the audience if there are.
Yeah, Dr. Akhilesh, if you could even enlighten our audience about steps, which we have the steps to eliminate TB in the private sector and the consortium. Yeah,
thank you, madam. Actually, we are having a system for TB elimination in private sector established 2 to 3 years back with the lead role from IMA Kochi. That time, Dr. Narayanan sir was the president. So there were with the community medicine department and respiratory medicine department of Amrita Institute, and there was several steps. That is, then there was an NTB consortium with private sector management, and also there was TB coalition. All the coalition members were involved. This API, IAP, so Thoracic Society, all these coalition members were involved. So their roles were assigned to enhance the activities. One is sensitizing, about the TB-free movement, like screening, mapping out the vulnerable populations. There are a lot of vulnerability mapping has been done under these programs. Then active case finding has been done. And the steps means whenever, this is a network between the government sector and the private sector. Means whenever any private doctor who is in single doctor clinic or is in a major hospital, he wants any service, even the RNDCP drugs earlier were not getting in the private sector. They were only available in the government sector. Now even it is available with the free of cost. It can be available with the free of cost with a request into the private hospitals. All the other services like sending a sample to or intermediate reference laboratory for line probe assay, that can be mobilized through district hospital, through the district TB center via steps. The free provision of the airborne infection control kit, that will be available to each patient in a private sector also via these steps. So it's actually linkage between the private sector and the government sector. From private sector, what government wants a mandatory notification and the utilization of all the public health initiatives like Nikshay Poshan Yojana and TB pension. All the TB patients, whether in a private sector or public sector, are eligible for this TB pension, at least this 500 rupees. And those practitioners who is notifying will also get a benefit transfer. That is for 500 rupees at the time of notifying, and outcome notification another 500 rupees, then 5,000 rupees for MDR tuberculosis. So this is actually a scheme for the linkage between private sector and public health system. Thank you.
I think not notifying also there is a penalty of 600 rupees. That's
600 rupees, madam. That is actually 2 years of imprisonment. Up to 2 years of imprisonment, IPC 269, 270.
Yes. And there is also the Scheduled H1 register which has to be maintained by both the pharmacies and the hospitals, where when you dispense the anti-tubercular medication. So that also is periodically it is checked. So even in a private pharmacy they have to maintain the register.
Any other questions? Just actually, I think we had forgotten to mention one thing. This is for the gynecologists and obstetricians. Pregnancy and postpartum period is not a contraindication for TPT. They have to be given TPT. And barrier contraceptives also, because those people who are on oral contraceptives, if you give a rifampicin regime, the effect is also, they are enzyme inducers, so the effect of oral contraceptive pill will be less. So they have to be given they have to use other contraceptive methods also. I mean, these are small things. That what I want to say is, not a single specialty is excluded from this. Gynecologist, pediatrician, orthopedician, everybody is included under this program, and I think we all should work together to make it a success. Thank you very much.
Thank you, madam.